When we consider what it means to reimagine aging, I think that's a very broad concept. And I think what we'd like to see is perhaps a change in perspectives on aging from both an individual, a household, community, societal, and even policy-making perspective. So, we often view aging as being a very negative phenomenon. If you talk to younger people, they don't want to get old. Aging is seen to be somehow a descent into senility and senescence, and it doesn't need to be. Clearly, we need to navigate and negotiate the biological and physiological changes that occur with aging, but often we can mitigate those by sense of purpose, by adopting a very different frame of mind, and maximising the benefits of getting older as much as seeing only the disadvantages. Likewise, we see rife ageism. We see data like half of Americans would rather die than enter a nursing home. So if that's their view of how society views older people and the value placed on older people, there's clearly a lot of work to do. At the individual level, reimagining the potential, I think, of aging. We've talked a little bit about in one of these series around life stages and maximising potential and reframing what can be achieved rather than mourning what has gone, resurrecting things that you've given up in your life and career, and maximising the potential as you look forward into enjoying an active old age. As far as disease and ill health goes, many older people are managing other chronic medical conditions. It's then again using that idea of what am I able to do for myself, what appropriate healthcare do I need to engage, and how can I maximise my quality of life whilst dealing with those conditions. If we consider when people might stop looking forward to getting older, I think that's a very individual perspective. Because it's age, it's often well said, old age creeps up on you. It's something that's going to happen to most of us. Increasingly, we're spending a greater proportion of our lives in what would be termed old age in the over 65 perspective. Whereas now we might view old age as actually being over 80. And this is really something that I can't answer. When do people stop looking forward? I think if people are dealing with a lot of chronic disease and living with disability and have a significant impairment of quality of life, then they may possibly look forward, cease to look forward to getting older. Obviously, as a physician, I deal with a certain group of people often who will say, don't get old, it's no fun. But of course, I'm dealing with the 5-10% of individuals who are dealing with multiple chronic diseases and do have those impairments with which we try to deal and maximise their quality of life. Clinical geriatrics is all about maximising quality of life for individuals who are dealing with multiple diseases. I think there are increasing data around this positive attitude to life, and undoubtedly positive mental attitude and mental health is wound up in quality of life, how one's perspective on physical disease and, if you like, your lot in life might be perceived. So the preservation of mental health in late life is increasingly important, and I suspect that as internal medicine physicians we don't always pay the attention to that we should, particularly when people are hospitalised with physical diseases. And ensuring mental well-being is paramount, and because that allows you to cultivate that positive attitude and then just enjoy things. We've talked again in some of these talks around the idea of perspective and attitude and maintaining and cultivating a positive attitude about things. And it's very much that glass half full thing rather than the glass half empty approach. And there are data to show that a positive attitude on life and quality of life has a positive outcomes in terms of health, quality of life, well-being, use of healthcare resources, and depression, and so on. So clearly it's very important. We do know that in younger people, this very positive attitude can actually contribute to early death because you take more risks, and that seems to be mitigated by knowledge and wisdom in older people. So as we all age, we will all have to positively engage with the changes that are going on. And I think it's really important to develop what we call in medicine an internal locus of control. That you have control over the things that you do. And there is, in managing most clinical conditions, a whole host of benefits that can be gained by self-management. You're not a victim, you're not done unto, and there are things that are your responsibility both to take action on part of yourself, but to realise where you need to seek help and seek that appropriately. So part of this is what we might call preventive geriatrics. So healthy aging in midlife and beyond is extremely important, and you may then postpone or control the likelihood of getting very late life diseases. And in one of our previous talks on healthy aging and healthy brain aging, particularly the spectre of dementia is writ large in people's view on late life. And there are things you can do in midlife to maybe postpone that or ensure that it doesn't occur at all. So internal locus of control, what can I do for myself? Well, how do I engage with the healthcare system around me? How do I preserve my mental health and what facilities are available? And that goes to community connections, engagement, both social and intellectual engagement, all being very much part of that mindset. You might ask then, okay, how has life for older people changed over the last 50 years? And we have, you hear these labels about Generation X, Y, Z, millennials, and baby boomers. So baby boomers post-war, and the life for older people has changed quite a lot in those 70 years. We've seen a difference in how people age, so they tend to be physiologically probably about 10 years younger than they were in the war at a similar age. Societal expectations and demands have also changed. In terms of healthcare, people expect more, demand more, see more doctors, get more diagnoses, get more treatments, expect more tests. And there may be then an over-medicalisation, but along with that has been an advance in life expectancy, less so in terms of healthy life expectancy, but largely due to advances in medical technology. So I think that you can see on the streets how older people might dress, behave, and expect things very differently from, say, the 1950s, 1940s. So tremendous changes, even when we talk about technology. There is still a huge fall off in engagement with technology in people in their 70s. Clearly, it's not, not homogenous. Though the people that are educationally, socio-economically advantaged engage more freely. But under that, we've got the majority of older people who aren't tech savvy, who do not engage, and unfortunately then are missed out. And that's a problem with many of the things, in fact, like this that we do. We don't reach the people who probably might benefit the most. So physical activity is all part of health maintenance. If there is one thing that one would want to avoid in very late life, it's losing mobility. Has a huge impact on quality of life, the amount of care you need and the amount of care that you can do yourself. So in part of that, physical activity protects heart health, protects brain health, elevates mood, and in my specialist research area, makes you less likely to become incontinent. So the benefits of exercise are huge. Doesn't necessarily have to be on a treadmill in a gym, but maintaining a reasonable level of exercise in which you become a little bit breathless is probably good for you. If you can walk and talk, well, that's okay. But regular physical activity, the benefits can't really be underestimated. When we talk about reimagining aging, I think we've got to also think about how we view retirement. Retirement used to be seen as a time to stop, to rest, to pause, and I don't think it can be seen as that. We know that due to financial calamity, people are having to work longer anyway, and perhaps it should be seen as a cessation of formal paid employment in terms of career. An increasing number of older people are engaged in the workforce, both in terms of paid employment and in volunteerism. Healthy, active aging, healthy, active retirement from the pensionable age is perhaps what we're talking about. And reimagining aging, spending that 25 years in tip-top condition to enjoy the benefits of your working life and your family is probably the target. But you need to prepare for that, and prepare for that actively, again, probably from midlife. Evidence suggests that people who say they're going to travel when they retire, yet haven't travelled up until retirement, will not do so. So we've seen an increasing number of retirement, active retirement courses, and making people aware of the potential of later life activities post-retirement, and that's got to be encouraged. You might ask then, what is the role of medicine and physicians in all of this? And certainly the role of my kind of physician is to manage late life problems and disease. And I suspect that we are perhaps too disease focused. In fact, the whole health service is set up to deal with younger people with one thing wrong with them and get them out. But who comes through the door is increasingly older people with multiple things wrong with them. We're good at managing that, and we can probably mitigate the effects of those diseases, but what we're not good at is downstream, is that preventive public health approach. We don't probably as a society devote enough to preventive medicine and to good public health. We have the messaging. We're not too good about the adoption and implementation and follow-up. So you will see in the press where you can prescribe exercise, but the follow-up on that and trying to incentivize people to adopt these healthy aging behaviors is probably still in its infancy. We've got data on how you can incentivize people to take up vaccinations, health screening, but we don't devote the time and resources maybe to the things that we should do in midlife and beyond that might maximize health benefits in late life. So we do have a problem, I think, with what's called health literacy in older people. It can be formally measured. We know that it falls off in association with increased aging. So I think if we're going to do really good value work, what we should be doing is ensuring that health literacy is maximised, that people can understand what they're being told or read. They are aware of what treatments are available for disease X, and they know where to seek help. For instance, we've just done a nationwide survey of Canadians in terms of bladder and bowel problems. There's a huge discrepancy between the sexes about knowledge of the condition, about what can be done for it, and about where to seek help. So we've been trying to attack that kind of thing, and it can be done by consumer charitable organisations in terms of public awareness campaigns. It scratches the surface, but I think in terms of society, we can do a lot for health literacy. We can make sure that we communicate in ways that people can understand, and try and equal that power imbalance where people feel somehow afraid to ask the questions that they want to ask for fear of being stupid. And of course we all know, or we try and say, there is no such thing as a stupid question. If questions remain, we haven't done the explaining right. whereas older people may be less health literate than younger people, often their children act as their health advocates and can help improve that. And that's particularly true where sons and daughters are tech savvy, and we'll see well-informed individuals come on behalf of their older relatives acting as health advocates. Now, if you can translate that to people currently in midlife and beyond, up to 60 or 70, as being an across-the-board phenomenon, that will have a huge impact. Taken correctly, it shouldn't increase demand, it should increase appropriate demand for healthcare services, but should also maximise the ability of people to manage their own health conditions. And of course we have these schemes called the expert patient, who have been used as, if you like, proselytisers of self-management, particularly for chronic conditions like arthritis or diabetes, and they can be of huge value. We've also trained older people to give educational sessions on healthy aging to other older people and shown that they can change behaviours as a result of that education. So that train the trainer approach is also very valuable, and we can improve health literacy in that way. So in other talks in this series, we've talked about engagement. We've talked about intellectual engagement as a way of maintaining brain health, and we've talked about social engagement and how that leads to improvements in cognition. But we've also talked about that sense of connectedness with community, society and family, and how that can improve health outcomes, largely because people can see if you're doing well or not, but also mental health outcomes and quality of life. It also helps people engage with physical exercise and pastimes and hobbies and things that they would not necessarily do on their own. We've talked about the benefits of eating together if one lives in a congregate accommodation, and how that improves nutritional intake. So that theme of connectedness runs through a lot of what we've been talking about. So you might ask, has the current coronavirus pandemic and the restrictions involved with flattening the curve and controlling demand on healthcare services has an impact on ageing? Well, it hasn't had an impact on ageing per se, if ageing is just the passage of time, but undoubtedly it has an impact on quality of life, isolation, mental health and well-being, all of which have a negative impact on health outcomes. And it may be where people are actually isolated or stressed, then you can see a physiological impact on physical disease. So that in itself, for instance, the increase in stress hormones and the neuroendocrine changes associated with that will have an impact on aging, and the organism will age, if you like, faster because of that. So when you discuss how you might age-proof a health system through innovation, it really stems from this idea that in terms of generating knowledge in research, it takes an average of 17 years to get that knowledge into practice. And what we're trying to do organisationally in Alberta is to compress that amount of time to rapidly test and implement new knowledge, but also to take existing knowledge and implement it within we've got an advantage in Alberta for a single healthcare system, to bring things to the fore as rapidly as possible so that people might benefit from that. And in fact, there's the Canadian Institute of Health Research who have actually said that if we stopped any knowledge creation now, it would still take a number of decades to use all of the knowledge that we have. So the idea of age-proofing Alberta was to improve the speed at which we implement things we already know to improve health benefits, but also to stop doing things that we know are of no benefit, and to allow people to be empowered and engage with their health system so that they might actively take up self-management of conditions, so we can because we know there are simply more older people with more conditions, and we need to somehow constrain or make sure that health care usage is appropriate.